Today, I want to talk to you about short-term mission trips versus capacity building trips. My name is Janey Phelps. I'm a pediatric anesthesiologist from the University of North Carolina at Chapel Hill. I unfortunately have no financial disclosures or relationships. However, I'm happy to establish one to promote global health and capacity building. My presentation does not include any off-label or investigational use drugs. So I imagine if you're joining this TED Talk, it's either that because you've done global health work or you have a passion for it. And if that's the case, you probably have seen this quote. This is from the 2015 Bangkok Global Surgery Declaration, and it is acknowledging that up to 5 billion of the world's 7 billion people lack access to timely and affordable surgical and anesthesia services. This is 70% of our world's population. So hearing that quote, you can think, well, we need both capacity building and short-term mission trips. And I just want to kind of talk to you about some of the differences between the two and why I feel that a shift should occur so that even if we do short-term mission trips, that there has to be a capacity building component so that we will get affordable surgical and anesthesia services to the 5 billion people out there that desperately need it. I want to show you this chart. This is from data collected from the WFSA, the World Federation Societies of Anesthesiologists. There are 135 member societies, and that's representing about 150 countries. In 2015, 2016, they sent out a survey with different follow-ups to try and determine how many MD anesthesiologists are located in these countries. They had 153 countries participate out of 197. And their goal was to see how many countries are below the 5 per 100,000 MD anesthesiologists, which is the bare minimum felt necessary to provide safe surgical and anesthesia care. As you can see, the countries in orange, yellow, and red are beneath that. Sub-Saharan Africa is the absolute worst, with some countries having less than 0.4 to 0.5% of MD anesthesiologists. That's 77 countries out of 197. If you actually look at non-physician anesthesiologists, a lot of countries do what's referred to as task shifting. So the anesthesia care are provided by either nurses or people who have special training in anesthesia, and in some cases, people that don't have special training in anesthesia. And even if you look at that population, 70% of 197 countries still lack 5 anesthesia providers per 100,000. If you compare this to some of the high income countries like the United States, they're at about 20 per 100,000. The Lancet Commission, some of their goals for 2030 was to have countries at 20 MD anesthesiologists per 100,000. To achieve that, there would need to be over 1 million newly trained MD anesthesiologists. To meet the bare minimum of 5 per 100,000, you're looking at 330,000 plus MD anesthesiologists that are going to be needed. Part of the reason that there are so few MD anesthesiologists in some of these countries is what's referred to as brain drain. 28% of physicians in high-income countries have actually trained in international settings. 70% of those are believed to be from Sub-Saharan Africa, and they actually are practicing medicine in high-income countries. Part of that is that they are living in a country that is not an ideal place to live. And within that country, medical practices lack resources, they lack infrastructure. There's an unclear path to professional advancement, so they make the decision to leave and go to high-income countries. It is estimated that 1 out of 5 physicians in Africa leave their country to practice elsewhere, and that significantly contributes to the desperate need for anesthesia providers and MD anesthesiologists in these countries. So why not have short-term mission trips? I mean, clearly there is a need, and if you are on this TED Talk today, chances are you can think of 5 different entities right off the top of your head that practice short-term mission trips and do a fantastic job with it. Some of the downsides to it is lack of follow-up care. Some people argue that some of these short-term mission trips talk more about output than outcome. There's really a significant lack of long-term outcome data from some of these groups. There's often a lack of support by the local host countries. Often there's significant language barriers, cultural barriers. It's short duration. Once you leave, the surgeries are done, but there's a significant impact on the disruption of the operating rooms. I had the opportunity of going to the country that I work at a couple weeks after one of these short-term mission trips, and I was surprised about the frustration of the surgeons and the anesthesiologists. This particular group took over all of their theaters. They had 6 theaters at the time. They brought all of their own equipment, all of their own medications, all of their own staff as nurses, surgeons, anesthesiologists. They did have some of the anesthesia clinical officers practice with them, which sounds fantastic. However, they're practicing on anesthesia machines that they won't have use of. They're using medications that they're not going to have in country after this group leaves. And so you question how much capacity building is occurring in that specific situation. A lot of people argue that this is another form of colonialism, which a lot of these low-income countries have suffered before. Somebody, richer and smarter and brighter is coming in and kind of taking over. There's a lot of concern about medical tourism. We feel really good when we do global health work. We get to see a new country. We get to help people. And that may not be the very best approach when you think about short-term mission trips. There was an article in 2008 by Maki, and they looked at how much short-term mission trips cost, and they estimated on average back in 2008, a short-term mission trip, one that takes all the providers, equipment, medicines, cost about $50,000. The US has the highest percentage of physicians that participate in short-term mission trips. And they estimated that if you use that money, you would have about $250 million from the US alone that could be redirected to capacity building, specifically looking at training and retention of MD anesthesiologists or MD physicians in general. I have been very, very lucky to be a part of UNC Project Malawi. UNC Project Malawi was created about 25 years ago, really focusing on research surrounding HIV and malaria. And since that time, almost every department at UNC has participated in some form of global health within UNC Project Malawi. Anesthesia got involved probably about 8 years ago. I think it's really important to look at the mission statement. It is to identify innovative, culturally acceptable, and affordable methods to improve the health of the people of Malawi through research, health system strengthening, prevention, training, and care. When I think about capacity building trips and capacity building in general, this mission statement to me is perfect for what the goals should be. So I do my work in Malawi, and if you're not very good with African geography, which I am not, I thought I would include a map. This is Malawi. It is a landlocked country. It has a beautiful Lake Malawi, but for the most part, it's landlocked. The capital city is Lilongwe, which is where I practice, but there's also a very robust city, Blantyre, as well. Both of these have anesthesia clinical officer training programs. And so when we partner with the anesthesia group in Lilongwe, we work at Kamuzu Central Hospital. Part of what we do is focusing on training, both providing continual medical education to the anesthesia clinical officers on the ground, as well as participating in the training of the TACOs, training anesthesia clinical officers. This is the first class that I had the privilege of being a part of. The anesthesia clinical officers provide the majority of anesthesia care throughout the country of Malawi. And one of the great things about partnering with a training program is that I'm not only having an impact, or our group is not only having an impact within that hospital, but throughout the entire country. A lot of these folks went on to practice in district hospitals, which have a dire need for anesthesia providers. We do multiple different learning objectives when we go. We actually were lucky enough to have an ultrasound donated. So we created an ultrasound workshop. This is one of our anesthesia residents who was participating on his global health elective, helping teach regional as well as venous access through ultrasound. One of our regional anesthesia attendings accompanied this trip to share her expertise with the group. We also had a low fidelity simulator donated. I'm a big fan of train the trainer. It's not just us going down and demonstrating our knowledge and teaching simulation or providing a simulation didactic, but it's teaching them how to use this equipment when we leave. Godfrey, who's working the computer there, is conducting the simulation all by himself while I'm a fly on the wall watching. And this way, all of the equipment is left and he can continue teaching simulation to his students while we are back in the US. We not only try and provide continuing medical education to the anesthesia clinical officers and help with the students' training, but this is one of the anesthesia residents on her elective, also providing CPR training to the intensive care unit nurses. One of the things that I'm most proud of is this is Henry Lizzie. He is an anesthesia clinical officer who is absolutely fantastic, who is currently finishing his second year starting his second year of medical school. Through our partnership, we are able to help fund his training to become an MD anesthesiologist with the goal of returning back to Kamuzu Central Hospital and improving the care that's given to the patients there, which is fantastic. And I think it's through these partnerships where we will get to a point where hopefully I won't have a global health job anymore, at least not at this particular hospital in Lilongwe, because we are training and educating and providing the future leaders of anesthesia. This is a picture that I have told myself I'm going to include in all of my global health talks because it's a reminder of why global health and capacity building is so darn important. This is a little baby who unfortunately died in part or mostly because an esophageal intubation wasn't recognized. They didn't have the ability to have an end-tidal capnography. They did not recognize a respiratory arrest as opposed to a cardiovascular arrest. And it's just a reminder to me why it's so important to have capacity building trips. And even if you are participating in a short-term mission trip, and I'm not to say that they're all bad and there's not a role for them, I feel very, very strongly that capacity building, training, teaching, developing long-term partnerships, even through short-term mission trips, is so incredibly important because we need to make sure that when you leave, you're leaving the anesthesia providers and the nurses better equipped to handle cases like these. I want to just highlight Dr. Mark Newton. He's at Vanderbilt University. He developed a tremendous capacity building program in Kenya, where he not only started a hospital, but a nurse anesthesia training program. Doctors Deb Rusi, as well as Kelly McQueen at the University of Wisconsin, is starting GAC. It's a global academic anesthesia consortium where they're asking other universities within the United States to partner with them so that they can identify a country in Africa and provide education and capacity building so that they're making sure that they're leaving that country better off because of their partnership with them. I'm very excited for our discussion, and I look forward to hearing from each of you and continuing this, I guess not even a debate, this approach of capacity building versus short-term mission trips. Thank you very much for your time.
Looks like we have a small, intimate group. So if anybody wants to unmute or add anything into the chat to kind of start the discussion, please do. And you guys can raise your hands or give a thumbs up in the Zoom thing. How many of you guys have done short-term mission trips? So one, how about capacity building trips? Or the short-term mission trip may have been a component of both as well. What are your guys' thoughts about the short-term versus the capacity building trips? I don't know if you guys disagree, but this would be way more fun in Hawaii, huh?
I thought since we're such a small group and you're all by yourself, I would turn my camera on.
Thank you so much.
It's not Hawaii, but
it still looks beautiful, that background at least.
This is South Florida.
Mm.
But that's a picture. I was going to ask you, I guess I'm trying to frame a question that, you know, it seems like I've done both actually. Short-term mission trips, medium-term mission trips, and capacity building with the ASA and CASIF teaching programs in Guyana and Ethiopia. And then I've done short-term team trips to South America and medium-term individual trips to Cameroon. And and I guess I just want to know what you think about, like, I think that capacity building is really important. And when you go there, people are interested in capacity building, but a lot of the invitations that people are responding to with these short-term trips really are invitations to do short-term trips. Come and help us, come and do this for us. And like the money question, how much it costs to do a mission trip, that's a real number, but it's not like that number would likely be actually offered to, you know, for another purpose. I mean, people will spend money on one thing that they won't spend on another thing. So I guess I just was wondering, like, kind of what how you want to parse that out a little bit more.
Yeah, I think that's so true. And there's also articles that actually look that even, let's say it's a complex surgery that the country cannot do, the money that it would take to send that kid to a high income country to have the surgery, some people would argue that that's a wash. And so the money aspect, like you said, shouldn't be an issue. And you can't necessarily redivert that money to, you know, capacity building. I think that the caveat to it is, I feel like a number of short-term mission trips, their goal is very simple: go in, do the surgeries, and go home. I would at least encourage that at least a day or two, as opposed to being spent just working, but really focusing on continuing medical education for the people on the ground, the surgeons, providing that to the surgical colleagues and or students and residents, and anesthesia to anesthesia, nursing to nursing. So that I do feel like there are those needs where you have to have people come in and do the work. But at least what I've seen before is when groups come in, the OR staff takes it as a vacation and they are out for the whole week. And I think that's not ideal. I think that there's a component of the two where you should bring in the folks who are on the ground to learn the skill. I was just in the country that I work at a couple weeks ago, and they had another short-term mission trip come in. And it was super interesting. The surgeon who needed the continuing medical education, that really needed to work with these experts, wouldn't operate because she wasn't getting paid, which is not, like, how do you fix that? How do you try and offer capacity building, but they're not interested? So I think having that long-term partnership is key, because if you don't know the people, you're more apt to not take their expertise. But if you have a relationship, then I feel like that's when people listen to you a little bit more. So I don't know if I 100% answered your question, but I feel like there's having a relationship with the home institution or the host institution, and really trying to incorporate them into the surgeries, and or at least providing a day of continuing medical education, I think is very important.
No, I think you point out some of the complexity of, why even capacity building is, in some places, is that really the real question? Is the short-term people going in and doing surgery for free? When there are surgeons there who are simply saying, well, we're willing to do the work if you pay us, it's complicated, because when we're here in the United States, we don't work for free either. And when we're training, we expect for the most part to be paid for that too.
Yeah, it's a good point. And whereas we often think we're coming to provide education, and they just sign up just for the educational component, similar to how we do with conferences or the like. Yeah, the more I do this work, the more I understand the complications surrounding it. It's fantastic. You've had such kind of vast experience in global health.
It's really been, in some ways, it's a huge blessing to have all these different kinds of experiences. And in some ways, it feels a little bit like floundering. I really like to, do one thing for a long time. And it sounds like, I don't know how many times you've gotten to go to Malawi, but it sounds like you've been also, the Cameroon is a long-term project, but, it's hard. It's a hard project to be a part of. And I'm sure that you run into some of those fits and starts in your work as well.
Yeah, it's one of the jokes that we have is, in Malawi, nothing's ever easy. So I think global health, you've got to have that personality of kind of go with the flow and expect some issues. Does anyone else in this small, intimate group have any questions or thoughts?
Can I just jump in? So
Yes.
I hear a lot, I think a lot of the satisfaction of people who go on these short-term missions comes from the idea that if I don't go, nobody does it, and the kid or the human might die or might not be helped at all. What do you tell them? What is the argument you come up with? I'm not a big fan of these short-term missions, but this is what I always hear, what people answer and where they get their satisfaction of going on the short-term missions.
Yeah, I think that's an interesting topic too. I think there's two components of that. One is the concept of the medical tourism. Why are we as an individual going? And then thinking in terms of, you may be going to help one kid, but if you're able, you don't just help one kid, you may be going to help 20 kids. But if you're able to incorporate some type of teaching and training and capacity building within that, then you can help, 2,000 kids if you really focus on that training aspect. There's, unfortunately, in these areas, there's never going to be, there's always going to be a plethora of children that need care and need surgery. And focusing on training and getting local providers and local surgeons and increasing the MD anesthesiologists in these areas, that's how you're going to get to the 2,000 kids as opposed to the 20. And so I think that's the big crux. I think that's the big issue. How do we make these countries with this huge need self-sufficient? There's one statistic out there that there only 3% of surgical specialists, anesthesia, obstetrics, and surgeons practice in sub-Saharan Africa and Asia, where there's third of the population live. So 12% of specialty surgical providers practice where there should be, or 3%, I'm sorry, a third of the population. And so the big issue to me right now is just that there's not enough people to provide the care and capacity building. I focus on the teaching and training and providing or increasing the local providers. So I think that would be the argument. You know, you definitely can help 20, but if we really focus on education, brain drain, and providers on the ground, then, you know, it's endless.
Yeah, the answer I usually get is, well, I'm not an expert in this and capacity building, let other people do that. Meanwhile, I at least save 20 kids. So it is like both should exist in parallel. And I understand that actually short-term missions might even cause harm. It is not like they are not living up to, you know, to build capacity, but they are actually cause harm locally.
Yeah, I think follow-up is something that we often minimize with these short-term mission trips. You know, some people, you know, for example, you read about in the literature, you have these heart programs go and they provide an artificial heart valve, but these patients never have the ability to do, you know, long-term anticoagulation. And so, you know, how does that play out? Or placing VP shunts when you don't really have, you know, the capacity for minimizing infections and or having them able to do operations when they do get infected. I think there's lots of concerns about follow-up with a lot of these trips. But I'm not, you know, I do think that there's a role and a place for both, but I do think they need to work together so that they're not exclusive of each other. I've been very, very surprised. My host institution where I do my work, their view of short-term mission trips, you know, prior to being involved with this and developing this relationship, I always thought, well, it's fantastic. Like you come in and you bring everything you need and you take care of, you know, 20, 30 kids in a week. I mean, that is amazing. But then to hear these locals and their impression of, you know, these short-term mission trips, it was really shocking to me. You know, I hear that, you know, now my list, it's 3 to 4 months before I get time in the operating room. And then now my operating room has been closed for a whole week because these other groups are coming in to do non-life-saving surgeries, which, you know, my list is for the most part kind of life-saving surgeries. And then, you know, the staff, they complain that their ORs are left in a shamble. They haven't put their anesthesia machines back. They're using all these medications that they don't know anything about. Like I've been very, very surprised the host institution's opinions.
I think this is a really interesting perspective. Is there any reference? Is there any can I read it up anywhere? Is there literature or other reports of these experiences from the local people? How they think about the missions?
Yeah, that's interesting. You hear a reference every now and again in various articles, but there's not a specific article related to that. It may not be bad for me to ask some of the local folks on the ground to maybe do an editorial or something about their opinions after the fact. This is more just conversations when I'm on the ground. I think an editorial would be a great idea. I would love to see that. Yeah, I'm a good friends with the pediatric surgeon there, and he often expresses his discontent. So maybe I'll see if I can partner with him to do something similar to that. Well, it is 10:33, so our 15 minutes of discussion has come to an end. Thank you guys for joining me. It would have been very lonely here by myself, so I appreciate it. And if y'all ever have any thoughts or comments or want to reach out, definitely do. My email is easy. It's janey@unc.edu. Thank you very much. All right, you guys have a great Sunday.
Thank you, Dr. Phelps. You too.
Bye-bye. Thank you.